So this video about the INI-CET November 2022 is about discussing everything based on the recalls given by my own students. If you do find that some option was different, we are more than free and welcome to please put your discussions on the live chat so that I can actually know what has been a different approach by you, or maybe has been differently or recalled by us. So guys, um, there has been around 25 to 30 questions both in set 1 and set 2 of the INI-CET paper. The first paper and second paper, I'll say, are equal in standard. There's not much of a difference having recalled both of them. The question has been same. In fact, I'll say the topics also have been picked up very similarly in the paper 1 and paper 2. That means that I don't think the paper 2 or paper 1 will have an added advantage over anyone each other, apart from the regular time that they have given the exam. Some of the images I will say was not of very good quality, but I've tried to, discuss this a lot with my students and who have been so helpful for me to give those images here. So guys, first of all, a very warm welcome to all of you who have joined this session for discussing the INI-CET paper. This is a paper 2. Paper 1 has already been discussed with me, and ensure that you have watched that video. If not, then you can just go to the previous video of this channel and watch that video also. Do subscribe to my channel to remain in touch with the upcoming plans as to what we can do for the upcoming INI-CET. I'm starting with the first question, and I always tell you that question on staining is very important. This is a question of the part 1, a chapter that is cell injury, adaptation, cell death, where the iron staining can be done with the help of, and this has a very simple answer, and all will agree the answer to this question you have marked might be and must be Prussian blue. So Prussian blue is one of the very important stain. It's also called as pearl staining, Prussian blue stain or the pearl stain. It is quite helpful in staining the iron. Prussian blue or the pearl stain. Mason trichrome stain is for collagen. Let me tell you, this has a trichrome, so 3 colors are there. So 3 colors means it can actually stain the collagen blue in color. Okay, it can stain the collagen blue in color. It stains the muscle red in color, and often the nucleus of the cells are stained black in color by this. PAS is a stain for glycogen and also lipids. Remember, the PAS for glycogen is PAS positive and diastase resistant, whereas the PAS for the PAS is positive in the glycogen and proteins. The protein is PAS positive and diastase resistant. Okay, PAS positive and diastase resistant. Now, one more stain that is given in the option probably was Fight Farrago. So Fight Farrago is basically a stain that is not a very commonly used stain, I'll say, but it is used for demonstrating the Mycobacterium leprae in the tissue section. Okay, the Mycobacterium leprae in tissues can be stained by Fight Farrago. So this is a new stain, and because the question has been asked, I think that you should all be aware of the same for the upcoming question that can be asked from the same topics. Okay, so the basic idea, often about solving any question is to not only know this answer, but also know multiple other questions that can be asked from this particular topic. The answer to this question should be Prussian blue here. Okay, match the following. So, a lot of questions this time came on the interleukin and cytokines. And if you remember, guys, that I always talk about in classes something called as TH1, TH2, and TH17 cells. So, among those, what you must remember is that TH1 cell releases IL-2. Okay, it releases interleukin 2, interleukin 12, and interferon gamma. So IL-2 basically activates itself and also activates CD8 T cells, whereas these two cells will activate the macrophages. IL-12 and gamma will activate the macrophages. The TH2, this will actually release interleukin 4, 5, and 13. And 2 questions came from the TH2 cells in this exam. The IL-4 will basically activate the B cell to release IgE. IL-5 will increase eosinophils, and IL-13 will often increase the production of the mucin from the mast cells. Okay, TH17 will release IL-17 and 22, and these two will then activate and release the neutrophils and the monocytes also. Now, based on this, what we can at least answer is that IL-4 will activate a B cell, IL-5 will increase the eosinophils. I think these two you might have all understood and marked in your answer. But what might have confused you are the other two options of our IL-13 and IL-9. So those who have attended my classes also always remember that IL-13, I have mentioned this in one more area, and that was in chronic inflammation when the APCs was turning actually to the M2 macrophage. APC changing to the M2 macrophage. Remember that I also told you one more area, interleukin 13 as such. When I talked about the macrophage being picking up the the MTB, and they are converting into M1 macrophage and M2 macrophage. So M1 macrophage will release the IFN gamma. I will change to the M1 macrophage. Whereas when the so-called antigen presenting cells or the macrophage, they release the IL-4 and 13, they change to actually the M2 macrophage. So actually the IL-13 is responsible for the stimulation of dendritic cells. Okay, and IL-9 is basically for the mast cell stimulation. So that's the right answer for this particular question. So even if you have not been able to answer, again know the answer, because this question can again be repeated in the upcoming exams also. If you do have any corrections, please message me, let me know, and I also incorporate your thoughts, your understanding into this session also. Okay, moving into the next question. So a patient presents with a hemoglobin of 9.8 and has a MCH of 24, MCV of 65. So low hemoglobin was there. There was a low MCH, low MCV, and ferritin was extremely low on this state. Platelet count was slightly higher side, and WC count appears slightly normal to bit raised. There was anisopoikilocytosis, and there was some images showing you pencil cells. A lot of anisopoikilo was there. Because of low MCV, low MCH, low ferritin, I think we could all have understood this question and marked this question answer as iron deficiency anemia. A similar type of question was asked in the session 1 also, where the answer was thalassemia. A lot of students have not been able to digest it, why it is not anemia of chronic disease. So discussion that I've done in the previous video, why was that not the answer of ACD, and why did I take the answer of that question as thalassemia. Whereas this question, where it looks to be more often a straightforward question, and answer looks to be a case of iron deficiency anemia. So sir, why it is not essential thrombocytosis? You cannot answer this question. This should have increase in platelet, there should be increase in megakaryocytes, and then you should have a mutation of JAK2. Only then there is a activation of the all three major factors, and then you can say it could be a case of essential thrombocythemia. Why did not megaloblastic anemia? Obviously because of low MCV. Low MCV, you cannot answer this question to be megaloblastic anemia. And why not thalassemia? Because thalassemia will not show you anyhow pencil cells, will also not show you any sort of low ferritin levels. Thalassemia often has slightly higher ferritin levels, because what happens is as you give more and more blood transfusion to those patients, they have often developed slight amount of secondary hemocirrhosis, because of which the ferritin levels increases. So remember, thalassemia will have slightly higher ferritin, and that question was also asked in second session of the INI-CET yesterday, and you might have all solved that question also. So again, I repeat why this question answer is iron deficiency anemia, because of low MCV, low MCH, and there is also surely some pencil cells being seen here. Okay, so the answer becomes a case of iron deficiency anemia. Well, now a similar type of question came, I think 1 year back in INI-CET, where it was very, uh, a blank statement given by INI-CET, that asking you the patient working who is a software engineer, and software engineer has been eating some junk food and has not been eating green leafy vegetables, and what is a probable answer? The answer would have been a case of folate deficiency. However, this case looks to be a case of hemoglobin 7 gram percentage, MCV 110, surely looks to be macrocytic anemia, and methylmalonyl coenzyme A was given as normal, but was giving you high homocysteine levels and was giving you vegan diet. I think they have to totally, remove that misconception that they arose after just a 1 year back, and they have given you a lot of history. So what happens here is, I think the answer you all have marked correctly, it's folate deficiency. So why it happens? You got two reactions you must remember. Homocysteine will convert to methionine. Okay, methionine, and this requires B12 and folic acid both. However, methylmalonyl coenzyme A will convert to succinyl coenzyme A with the help of B12. So if there is a B12 deficiency, so then this increases. However, if there is either folic acid or B12 deficiency, then homocysteine increases. In this case, it is giving you a normal level of methylmalonyl coenzyme A, and therefore, I think it's a straight away you could have answered this question as folate deficiency. If I tell you B12 deficiency, this often happen in case of a person who is a vegetarian, a completely vegetarian, okay, and will have increase in the methylmalonyl coenzyme A and decrease in the succinyl coenzyme A. Okay, that should be there also. Okay, that should be a typical history. It cannot surely be a case of thalassemia also because of similar type of history not being available here. So this looks to be a straightforward question and the answer looks to be a case of folate deficiency. Okay. Now look at this question. So there is a child having multiple lytic lesion skulls. Though when you have this image with multiple lytic lesion, you can think about a case of, yes, you can think about a case of either metastasis, okay, think about METs. You can think about Langerhans cell histocytosis. You can think about multiple myeloma mostly. But look at the age, child hai. So in a child, you have already excluded out metastasis. You also excluded out multiple myeloma. So even without knowing what the question is, the answer should be a case of Langerhans cell histocytosis, giving you S100 and CD1A in a staining of the IHC. So what also you must know is that usually the H&E cells, they show you a typical grooving like this. Okay, this type of grooving cells are seen. There are grooves. Okay, they are nuclear grooves in the light microscopy, and even though it's not given image, but the electron microscopy image was also very frequently, has been very frequently asked. They show this type of cell called as Burbeck granules. Okay, and this Burbeck granules is what will often stain positive with CD1A and C207, 207 being the most specific stain, and is actually called as Langerin. Okay, this actually is called as Langerin. But when you have an answer of showing UCD1A positive, S100 positive, I think there's no doubt it should be a case of Langerhans cell histocytosis. Well, sir, why is not Rosai-Dorfman disease? A Rosai-Dorfman disease will now show you a very important history of emperipolysis. Okay, the two disease which is Kimura and Kimuchi. The Kimura and Kimuchi, they are necrotizing lymphatic lesions. They are lymph nodes in which you can see necrotic lesions. Okay, and xanthogranuloma will show you surely show you a image of granuloma, and hence it cannot be xanthogranuloma also, even though xanthogranuloma is not a very common thing to be seen. But this typical history with us showing you S100 positive and CD118 positive with a multiple lytic lesions should be a case of LCH, Langerhans cell histocytosis. Previously some classification was done, but those are not used nowadays. Just remember, it is either a localized or a widespread LCH. That is quite possible there. That are all the questions that have been asked from LCH here. Okay, guys. Now, this is the next question of GSPD patient after treatment with drugs had developing hemolysis, drug used. So this is again a question straight away from my notes. I'm very happy to tell you that a lot of questions actually have come straight away from my notes also, not even I'll take my book or my Gurukul notes. So class notes have been very much effective here, and this becomes a straight away case of primaquine, which is a JXP deficiency having developing hemolytic anemia. But yes, you must also know some other drugs which can cause this, which can be a probable question. It could be, remember, anti-malarials like primaquine. The chloroquine is always plus minus, quinine, sulfadoxine. So these are basically anti-malarials. Apart from them, some antibiotics like fluoroquinolones, it can be dapsone and can be vitamin K also. So all of them are the most possible operable drugs which can lead to G6PD, which can lead to G6P deficiency, and in that case there can be severe hemolysis. Tetracycline is not supposed to show that, but this is plus minus, and if there are multiple choice question, you can also pick up chloroquine. In fact, chloroquine was one of the previous repeat question in which the primaquine was not in the option, and then you had to choose a patient of chloroquine showing you hemolytic anemia. Identify the correct statement. Now, this is a not a well I'll say recalled question, but my students have been able to give me at least two options. So one of them showing you IL-12 activates macrophages. So I think this is the question I was talking about. Just come back here. I've already talked about this scenario, remember. So this is the straight away question being asked twice. देखो, so when I talked about the Th1 cells, they release IL-12 and IL-12 activates macrophage. So this statement appears true. The second statement was IL-12 suppresses T cells or inhibits cytotoxic T cells. Well, this is a false statement. Okay, so if the option was recalled like this, I'll say the first statement was true and the second statement actually applied was false here. The third is activates interferon gamma. So surely if you talk about the IL-12, so IL-12 will not activate interferon gamma but will activate macrophages which will then release IFN gamma. So I'm not exactly sure that what the other option was. Someone saying that the other option is seen in immune histocytosis. Was that the correct option? The D option? You are saying that it was. So I think you can please let me know what the other option was here. Anyone who is watching this video, if you can let me know what the fourth option or the third option, I'm missing it here. But in this case, this app is true and this app is false. But if the option was suppose IL-12 will be activating CD8 T cells, then surely that's a true statement. But what I have been told is that IL-12 was inhibiting suppressor T cell. That's a false statement. Okay. So what you should know is that IL-12 will basically activate the macrophage and the macrophage will then again release IFN gamma to actually cause a granuloma formation. So if you can please let me know what the other option was here, it's very kind of you to let me know here. Okay, I'll come back to this question once you answer me here. Poor prognosis factors of ALL. So remember the prognostic factor of ALL in the WHO 2018 classification of ALL talks about some good and some poor prognosis. Remember, if you talk about the good prognosis, it's only one 12, 12 ko ulta karo 21, and in the poor, it is translocation of 9 with 22, any chromosome with 11, and it can be 5 with 14. Okay, so among these, so these are all the poor prognosis. So 411 is poor prognosis, 922 is again poor prognosis, less than 1 is poor prognosis, and hyperdiploid is the right answer because this has a good prognosis. Okay, has a good prognosis. So I will say that the correct answer to this question should be actually what it should be. Yes, it should be hyperdiploidy. And if you remember, please do revise that good and poor prognostic table. For AL, we always draw this table. Less than 1 year is good. More than 10 year is poor. याद नहीं ऐसा favorable and unfavorable. Please try to recall all those important steps for the upcoming NEET PG. What are the favorable and what are the unfavorable condition for ALL? So age wise अगर देखोगे less than sorry between 2 to 9 year is a favorable, less than 1 year or more than 10 year is a unfavorable prognosis. The females have better prognosis compared to males. The TLC of less than 10,000 is still favorable. Above 2 lakh is unfavorable. Any WHO classification of translocation 12 with 21 is good, and all others like 5 with 14, you can say 9 with 22 or V with 11, they all are unfavorable. Remember, there is hyperdiploidy, it's good, and hypodiploidy is poor. Not to forget that if you talk about the trisomy, so trisomy of chromosome 4, 10, and 17 are favorable, whereas all others are unfavorable prognosis. So please do recall these. Apart from the remission rate, if the response will come within 7 days, it's good. If it comes beyond 28 days, is poor prognosis for a case of ALL. Now, I have been given some other recalls for the previous questions. Like one of them, sir, other option was IL-12 activates Th1. So that looks to be a very true option. So IL-12 will actually activate the Th1. That also looks true. And interleukin 12 secreted by macrophage. So yes, that's also is true. So the third option was, I'll say the third option, C. Option C will say that, sir, IL-12. Okay, IL-12 activates Th1 cells and IL-12 is secreted by macrophages. This also looks to be a true statement. So I think in this case, the option B looks to be a false statement because it was a multiple choice question there. So am I correct here? And this is the answer. Hyperdiploidy is the answer to the next question, which you all should be looking up here. So guys, moving to the next question quickly. Now this is again a question from my notes, rheumatic fever. I think you might all have marked this correctly. A 11-year-old child with diagnosis of rheumatic fever without valve damage, what is the duration of secondary prophylaxis required? Well, secondary prophylaxis required. That is the question asking you here. What have you marked here? Well, remember, the answer when there is without valve damage, the answer should be very clearly. Tell me, देखो, you should read as rheumatic fever without carditis. Up to what age or what duration you must give the treatment. Remember, the treatment given is benzyl penicillin. Okay. Rheumatic fever with carditis but no valve damage, and rheumatic fever with valve damage. The three conditions which you must all be aware of, and this question was first asked in this year's NEET PG also. The same question was repeated. ठीक है ना, तो इट वाज rheumatic fever without valve damage was the question. So क्या होगा इसमें आंसर? It is actually for given up to 18 years of age. Some books say 21 years, same only, and duration for 5 years. It was then 18 years or 21 years and was 10 years, and this was age up to 40 years, and duration for 10 years must be given, or sometimes even lifelong it could be given. So this surely the answer becomes a case of 10 years, no doubt about this statement. Okay, that is the right answer here. I also saying the same thing, rheumatic fever without valve damage was the answer, was the question given, and therefore the answer is 10 years. The same thing that you are saying, I'm also saying the same thing. Okay, so I move ahead. Okay, saddle nose, caseating granuloma, giant cell with history of fever, weight loss, hemoptysis, and lung multiple cavitations lesions was seen. Exact question which I've discussed multiple times in my own classes. The answer is surely a case of vaginous granulomatosis. Well, uh, the question is giving you a history of saddle nose, case-eating granuloma, and giant cell. These three things have given you a granuloma with giant cell, and there is fever, weight loss, and hepatitis with multiple cavity lesions in the lungs. It straight away becomes a case of vaginous granulomatosis. You know, the simplest way to solve this question is to looking at the table. This table I teach in my own classes. I just repeat the table for you. How to remember the three small posse immune vasculitis. Suppose one is question is on Church-Strauss, and one question is on vaginous granulomatosis, and one question is on microscopic polyangiitis. The three things you must be taking care of: Anka, what are the clinical features, whether they show granuloma or not, and if they show any finding of RPGN. देखो, फर्स्ट ऑफ ऑल माय वे ऑफ एप्लीकेशन इज द रिमोनिक PCM. सो अंका में PCM मतलब P अंका is seen in Church-Strauss. Okay, P anka is seen in Church-Strauss and microscopic polyangiitis, whereas vaginous shows the C anka. So mnemonic is PCM. Now, if a patient has a history of RPGN, granuloma, and along with that they have a history of allergy or eosinophilia, it becomes a case of Church-Strauss syndrome. If a patient has a history of RPGN granuloma with upper respiratory tract infection and lower respiratory infection, and along with that, if they have lung cavitations, it becomes a case of vaginous granulomatosis. Suppose you see a history of RPGN, no granuloma, and no such finding, it straight away becomes a case of microscopic polyangiitis. The simplest way to solve any question on small vessel posse immune vasculitis. The upper tract infection in the vaginous will include sinusitis, will include pharyngitis, otitis media, swelling of gum called as strawberry gum. It can also cause the necrosis of the you know septum called septal perforation can happen, salon's deformity can happen. The lower tract infection often includes pneumonia like features, and not to forget lung cavitation is also a feature of the vaginous granulomatosis. I think this is simplest way to solve the question because this is very frequently asked and you should be aware of such type of questions. Okay, chalo. The following is a correct statement was one more question. Most of the stomach cancer are hereditary. So E. Catherine loss causes diffuse type. Intestinal type is called by WNT mutation, and depth of invasion has no prognostic value. Let me tell you what exactly the question is asking you. Please remember, this question has been discussed by me in the vibe session. So please ensure um, the question should be understood, and vibe is very very important for you all. Do ensure you watch the vibe before the NEET exam also. This question has been discussed by me in the vibe. There's an image also giving a signet ring appearance there. So most of them are hereditary, that's very true. E-cadherin causes diffuse type, and this intestinal type is mainly caused by the P53 mutation, and depth of invasion surely has prognostic value. So this statement, this one is a false statement. Answer is A and B. Answer must be A and B. Well, in the previous question, why it is not here a tuberculosis case? Because TB should not show usually a case of Saddle-Nose deformity, and the TB also must show you AFB positivity. That's one other history that should be shown in a case of tuberculosis. The Saddle-Nose deformity is asking you to know whether the answer is vaginal telangiectasis or not. It's a very characteristic feature, and multiple lung cavitation is again a very typical history of vaginal telangiectasis. So know about these cancer. Please understand and remember about the two type of gastric carcinoma. One of the gastric carcinoma you should be aware is diffuse type. Okay, I've discussed this topic in vibe. Please understand and please do watch vibe before attending for the main exam. So diffuse carcinoma, and one of them is a intestinal type of carcinoma. Okay, so how to remember this? Remember, diffuse carcinoma is due to CDH1 loss causing cadherin loss, and this due to P53 mutation. Okay, so here the cells are all discohesive. Because the cells are discohesive, there can be a nuclei, and a layer of mucin can push the entire nuclei to one side, and that's what is called as a signet ring appearance. Because they can invade the muscle more, the stomach can become like this one. It is called as leather bottle or lanatus plastica. Lanatus plastica. However, this shows malignant glands in which you see deeply cohesive tumor cells arranged like this. This cohesive tumor cell is a finding of intestinal type of carcinoma. So in carcinoma stomach, false state was asked. So beta dekho, if the false was asked, then the answer will be C and D. Okay. So if false was asked, the answer must be 3 and 4. But true is 1 and 2. So I'm very thankful for you for letting me know what the exact answer was and the exact question was. Please do tell me what the exact was question was. Will really help me to recall it in a better way. Okay, guys. So till now, do you have any doubts? For those who are not subscribed to my channel, do ensure that subscribe it, because coming days may we'll have a lot of discussion to topics based on the NEET and the INI-CET recalls. So ensure that you subscribe to my channel and let me know if you have any confusion anywhere, and I'll also teach you those topics in a very short duration of time, maybe by a short video or just by a random discussion with you all at a particular amount of time. Okay. Match the following. So I think this is the right answer also here. Match the following. So Sézary cells showing cerebriform nuclei. Yes, that's true. Faggot cell, APML. I suppose match the following. So I have already matched it according to the right answer. So let's not discuss the right true and false. This actually is the right answer here. These all are true here. And Burkitt lymphoma shows starry sky appearance. Popcorn saying showing in the P for popcorn, P for predominant. Faggot cell are cluster of the or rods being seen in the acute myeloid leukemia, and Sézary cells often is seen in a case of cerebriform nuclei. Is seen in this case of cerebriform nuclei. So right answer to this question is this the same answer is the right answer here. I've already arranged this in the right answer. I don't think you might have any doubt in this question actually. Hereditary angioneuric edema occurs due to deficiency of. So this is one question which I always ask you all. Write in the notes when I teach you about the complement system. I mention everything about the complement in a single page, and the answer is C1q inhibitor. Okay, C1q inhibitor is the right answer. And do understand that complement is very very important. Try to remember that the C C3b, C4b, C5b are opsonin, C5a is a chemokine, C5 to C9 is a membrane attack complex. Do remember the function of C3a and C5a together, they lead to anaphylotoxins, and then the deficiency of CD55 and 59 leads to PNH. Deficiency of C1 esterase inhibitor leads to C1 esterase inhibitor, yes, it leads to hereditary angiotic edema. Not to forget, the deficiency of factor I and H can lead to atypical HUS. Okay, so do revise these things. These are very, very important for the upcoming NEET also. Do not look at these questions just for knowing the answer. Ensure you revise these topics when you revise the entire subject again you need preparation. That's very important to understand, and do not be at all bogged down by anything which has happened in the NEET exam. Let your preparation remain as it was in before the NEET exam. A child presenting with hemolytic feces and there's splenomegaly, history of multiple transfusion, which all investigations will you do? So this is a case of, yes, it's a case of thalassemia. So this looks to be a case of thalassemia with this child and multiple blood transfusion history. You'll do peripheral smear and HPLC. The answer is both 1 and 2 you will do. This is neither a role of bone marrow in diagnosing the hemolytic anemia like thalassemia, and definitely the PT if it is out of question in such patients because not a coagulation abnormality. So answer must be 1 and 2 because a case of thalassemia. Thalassemia may read everything about thalassemia, know about the peripheral smear finding, know about the low retic count in thalassemia. You should know about the screening test called as the Nestrov test, and not to forget the HPLC finding may HbA2 is increased in case of thalassemia trait, but A2 and F both of them increases in the case of thalassemia major. ये सब कुछ जरूर ध्यान रखना. These are basic things which you must remember. And if the question is best investigation for a case of thalassemia, not to forget the best investigation always a mutation analysis, especially in the beta gene. There should be a mutation analysis. That is again a very frequently asked question from thalassemia. Okay. Okay, Epstein-Barr virus target which receptor on the B cell? ये तो question हम बनाते हैं. We all draw this in our own notes. So I draw the cell like this. Is a B cell. Okay, the B cell has IgM or IgD. Sorry. Sorry. The antigen acts here, and apart from them, there is a CD21. Okay, this is CD21, also called as complement receptor 2, and the Epstein-Barr virus will enter a B cell via CD21. So right answer to this question is the CD21 through which the Epstein-Barr virus enters inside. EBV के ऊपर a lot of question came this time. So it was one of the question was proto-oncogene, which was E6 and E7. One question was vaccine strain, which is actually the L1, L2. So those are all very important in the human papillomavirus and also in the Epstein-Barr virus. So HPV के ऊपर 2 question came and Epstein-Barr virus 1 question came. That was this one. CD marker is one thing that you must revise before the exam also, guys. I'm telling you कि CD marker के ऊपर question नहीं बन सकता. Okay, so ensure you remember everything, and I usually talk about them especially in hematology and also in immune system. तो immune system का जो topic है NK cells, about this pattern recognition receptors. Like here also one more question came in the first session, and the question was about how does the IgM and IgD both of them are seen together, and that question is all based on the somatic hypermutation that occurring in the B cells. Now, a patient has papillary carcinoma thyroid. The following are the features that you can see in a case of papillary thyroid carcinoma. So remember, in a case of a papillary thyroid carcinoma, usually in biopsy, you see the follicular, you can see the papillary pattern. You don't see increase in the follicle. That's not the thing that you can see. Concentric calcification of samoma bodies may be surely seen. Samoma body का simple mnemonic में पढ़ाता हूँ आपको PSM, मतलब papillary carcinoma, serous carcinoma, and meningioma. Nuclear reading is also the right option, and nuclear grooves is also seen in a case of papillary carcinoma. So usually they show you the nuclei like this, or you can see the nuclei like an orphan Annia nuclei, and definitely they can show you the concentric calcification. Nuclear grooves was most of the options was having the nuclear grooving, so that I don't think might have confused most of you who have given this option. So papillary carcinoma thyroid is actually a tumor in which the tumor looks from the round follicle. ऐसा follicle होता है ना, so they have follicle cells like this. and between them there is normally colloid like appearance, has a normal follicle होता है. तो what happens in papillary carcinoma is this typical will change to a papillary shape ऐसा. Okay, and in the papillary shape the cells actually have a orphan Ani nuclei. Papillary carcinoma thyroid में two question came in the second session. One was in papillary carcinoma, one was in medullary carcinoma, and one question came in the first session that was again asked in papillary carcinoma. Okay. The nuclear cleaving can be seen on FNAC also, if that at all was the option. So FNAC में we can see nuclear clearing also, we can see nuclear grooving also, and we can also see calcification. ठीक है ना. अगर even if the option was FNAC, you can easily see the nuclear grooving also in a case of papillary thyroid carcinoma. इसीलिए ना the FNAC is diagnostic in case of papillary carcinoma, it is not diagnostic in the case of follicular carcinoma. Okay. Non-smoker female has adenocarcinoma lung. What are the markers which is positive here? Well, this question is showing you it's an adenocarcinoma of lung. Now remember the markers and the IHC. IHC के ऊपर तो इस बार because ताबड़तोड़, you know what I say in my classes, and many of you who are actually watching this video will actually tell you whether it's true or not. अपना नाम भूल जाना, but immunohistochemistry मत भूलना, CD marker मत भूलना. इतना important होता है these two, and this was actually the question formed here. ठीक है. The adenocarcinoma lung, it shows, देखो एक होता है squamous cell carcinoma और एक होता है adenocarcinoma. ठीक है. So because both of them are carcinoma, they both will show you CK positivity. You cannot comment on that. But if you talk about a specific P40, P53, P63 are positive in squamous cell carcinoma, this shows TTF1 and napsin. TTF1 and napsin is positive in adenocarcinoma. So both of them, A and B, must be the right answer here. ठीक है, both A and B must be the right answer. Remember, chromogranin is positive in the, yes, neuroendocrine tumor. Okay, chromogranin is positive in the neuroendocrine tumor. Neuroendocrine tumor. And P40 is positive in the squamous cell carcinoma. Napsin and TTF1 are positive in a case of adenocarcinoma of lung. ठीक है. Next question, number 19. A 26-year-old female patient has hemoglobin of 5 and retic is 9. What is the correct retic count? अब बताओ, जिसने मेरा क्लास ज्वाइन किया वो ये सॉल्व किया है. मेरे क्लास में आई गिविंग यू ओनली वन ऑप्शन एंड दैट इज दिस क्वेश्चन. सो retic percentage into hemoglobin or hematocrit of the patient divided by hemoglobin or hematocrit of the normal person. So in this case, retic percentage is around 9 into hemoglobin is 5 and normal we take as 15, बन गया 3%. The answer clearly is 3% here. That's the right answer. ठीक है, that's the right answer. This is a correct retic count, and do also revise everything about reticulocyte count. There's staining, which is a supravital staining. There are 3 examples: crystal violet, you can stain with new methylene blue, and you can also stain with the case of the brilliant crystal blue, new methylene blue, and crystal violet. The normal retic percentage is 0.5 to 2% in adults and 0.5 to 5% in children. High retic indicates hemolytic anemia, low retic indicates it could be a case of hypoproliferative anemias. So ये सब important है, please इसको revise कर लेना before the main exam. कुछ doubt हो, I'm always there to please message me. I'll also be replying it to you that way. Okay, MEN2 syndrome. How many of you became happy? इसको तो मैंने अपने क्लास में कितनी बार पढ़ाया, सबको याद कराया. कैसे याद कराया? MEN1, MEN2A, MEN2B. कैसे याद करोगे? 3P, 3M and are you happy? सबने बोला हाँ सर, we are very happy. बोला था कि नहीं? No, 3P is क्या क्या है? Yes, बोलो, pituitary, then pancreas and parathyroid. 3M क्या है? म्यूकोसल न्यूरोमास, मार्फिनॉइड हैबिटस, है ना, एंड मेलिटरी थायरॉइड कार्सिनोमा. और हैप्पी क्या है? हर्शस्प्रंग, अमालॉइड, फियोक्रोमोसाइटोमा, parathyroidinoma, and Y is the Y of medullary thyroid carcinoma. What is common about all these three is the FIO and FIO. ऐसे याद तो किया था ना हमने, ओके। एंड म्यूटेशन, ये क्या म्यूटेशन है, मेन, ये क्या है, आर ई टी रेट, ये क्या है, आर ई टी रेट, विच इज सिपल सिंड्रोम, टू वाला है एस आई डबल पी, सिपल सिंड्रोम, वर्मर सिंड्रोम दिस, और क्या आपने याद किया है, मेन फोर, यस सर, मेन वन, इफ द पेशेंट हैज सी डी के फोर म्यूटेशन इट बिकम्स अ केस ऑफ मेन फोर। दैट इज हाउ यू मस्ट रिमेंबर मेन सिंड्रोम। इसके ऊपर क्वेश्चन आ ही नहीं सकता। राइट आंसर इज 1 and 2. Parathyroid hyperplasia and medullary thyroid carcinoma are what you see in a case of MEN syndrome. Now, this is one thing which I have not discussed with you in the recent eras. I completely agree. And but if you have attended your second year, or first year physiology class, I don't think it's done in pathology also. But yes, that's one thing which you do in physiology also. I'll just show you how do I teach this to my second year students, because we should be able to recall that. देखो, so this is a case of, देखो, this is a case of acid hematin. यहाँ पर what we do, just recall this very quickly for those who are here. Hemoglobin is mixed with 0.1% HCl and that becomes acid hematin, brown in color. But it cannot measure self hemoglobin or carboxy hemoglobins, okay? 0.1 normal HCl with 2% mark in the hemoglobin tube is measured. Okay, तो पहले यहाँ पर we measure this into 2 up to 2, we put this up to 2, and then 20 microliter of blood is mixed with this. Okay, transfer in the hemoglobin tube and then it added in the hemoglobinometer and try to match the color by diluting it. Mix or add water to match the color, and this suppose has matched at this level, and here 8 is written here. The answer of this is straight away 8. So 8 written here, 6 and 4 and 2 is written here. So at whichever level the color of this tube will match with the surrounding color, it becomes a case of that polluted hemoglobin. The basic principle is acid hematin. Okay, basic principle is acid hematin is brown in color. It cannot measure self hemoglobin and carboxy hemoglobin. So this answer is acid hematin. Now this is a hemoglobinometer. So this tube is taken from here and this tube is added here in this area. Okay, the color is matched to this tube with the surrounding area here and here. Whichever is the color matching, that is the hemoglobin that is given. But this test is not done nowadays, but that's for recall purpose. They have given this question in the evening session of the INI-CET yesterday. It's a very it's strange to get this type of question nowadays because this is not at all done. But since it is practice in first and second year MBBS practicals, so I think that's a very logical way of asking the question based on recall or memory basis, that whether you have at all gone to the second year and first year sessions in your medical college or not. Okay, even though I have made a video also in my this same channel. I have made a video of every instruments, so go through that. It'll just take half an hour for your preparation. I made every video of the possible instruments that can be asked in your main exams. Okay, 22 iron overload investigations in thalassemia major, patient who has multiple blood transfusion, best investigation is. Now I know that when I answer this question, a lot of you will again be thinking that I am not correct here. But guys, let me tell you, the answer to this question is actually serum ferritin. The answer is serum ferritin, is not liver iron concentration. And to make you understand this, let me tell you what and why is the answer here. Dekho, what happens is, this is the area of Wintrop's hematology, in which I have taken out this part, and I just want to read for you all here that what does Wintrop's talk about this entire area. Dekho. Okay, this is a part of the Wintrop's. I'm just reading these lines for you and telling you why is the answer as I tell you here. Dekho. So assessment of iron stores is the basic point here. Okay, assessment of iron stores. So what is this question talking about? There is a patient who has just come back here. Yeah, देखो. Serum iron is always elevated. Transferrin level correlates reasonably well with the serum ferritin. After only a few years of transfusion, however, transferrin is completely saturated in a majority of the patients. In thalassemia major, serum ferritin has been generally found to be correlating well to the iron stores as measured by phlebotomy and with liver iron, either measured directly or by liver biopsy or MRI. So this is telling you the serum ferritin is as good as a marker compared to liver iron or by the other methods of liver biopsy also. So when you go down, it talks about despite all this, serial measurements of serum ferritin remains a reliable mean and the earliest one to evaluate iron overload and efficacy of chelation therapy. And therefore, the answer to that question is serum ferritin also. It should not be a case of serum liver iron. अब गलती हो गई इसको मान लो. If the same question is repeated, you will not do the other again the same mistake. But one more very good option that was asked this year in this same Wintrops hematology given was MRI R2. This was also the option given to me by my students. So clinically, via a reciprocal T2 star is widely used for elevation of iron in myocardium and liver. So if you want to do this in a iron levels in the liver and heart, T2 MRI is one golden way of doing the same thing, but is not very easy to do that. Okay, now remember, iron deposits shorten the T1, T2 and T2 dash. The T2 dash has become the more widely used because it is more sensitive to iron deposition, but this is used only and only for if the iron is there in the liver and the myocardium. Elsewise, we do not use this mostly in the other cases. So for understanding this part, please remember the answer, best answer is serum ferritin. If not in the option, you can go with liver iron, but nowadays this is a very new technique and this would be available after a few years, but right now it's not very popular to be used there. Okay, so answer this question is serum ferritin. I know you will not agree with me, many of you will not agree with me, but that's a truth and you must be able to understand this for the future purpose. What has happened has happened. Let's not even bother about what has happened in the past. Okay, so it's okay. आगे बढ़े. If you find this session good, please put a like on this video and I'll ensure that I'll revise on whatever possible way you tell me कि sir please revise this topic or that topic. I'll surely revise it for you, but do subscribe to this and also put a like to this video if you want, if you feel the session is quite beneficial for you. Okay, MTC histoimage came, sir, and this was the histological image for Melville thyroid carcinoma. याद रखना that if you get a thyroid histology with a amyloid deposition, okay, a pink color acellular amorphous pink color amorphous pink amyloid deposition, it becomes a case of Melville thyroid carcinoma. Okay, Hashimoto thyroiditis will show you Hurthal cell change. Okay, Riddles will show you fibrosis of the gland, and Papillary carcinoma will show you the nuclear clearing, grooving, and also will show you the basic papillary structures there. And so this will show you orphan Annie I nuclei. It will show you the papillary pattern, and not to forget, it will also show you the finding of calcium deposition. And so right answer to this question looks to be a case of Melville thyroid carcinoma. Melville thyroid carcinoma. Now this was one image in which students have really complained a lot to me कि sir the image was very bad. What to do, and where the entire world is going towards a 4K resolution. It's so heartening to see that image of quality as bad as that you cannot even make the hair in this area was given in your exam. This looks to be a case of mature cystic teratoma. This was an image based question and this is also discussed. Okay, it is also discussed in my vibe session. मैं फिर से बता रहा हूँ, during your question preparation in the next revision, ensure you watch the vibe videos also. It is really a very good way of revising the entire topic, and I have just made a 2 hour vibe session video. Usko dekh lena zarur se. Okay, it's a mature cystic teratoma. Okay, so sir, why not immature? Immature will show you it is malignant teratoma first of all, so it will show you immature tissues. Okay, including, it won't show any hair, no hair is seen, only immature tissue are seen. Cystic, cyst adenoma, serous cyst adenoma, serous cyst adenoma. Now this shows a serous fluid. Okay, clear serous fluid in a case of the ovarian tumor, and mucinous will show you a large thick mucin. Okay, thick viscous mucinous fluid in the mucin cavity, and therefore the right answer to this question actually is a case of A. It is mature cystic teratoma. Okay, mature cystic teratoma. Mature cystic teratoma. Mature cystic teratoma. Okay. The following cytokines are released in Jerish Hexamer reaction. Jerish Hexamer reaction जो आजकल होता नहीं है commonly, उसके ऊपर क्वेश्चन पूछा गया. It's a factual question. I will not be discussing this in a lot of detail, but the answer to this question is TNF alpha and IL-6. देखो, interferon alpha तो होना नहीं चाहिए. Okay, and IL-8 often leads to neutrophil chemotaxis, and therefore should not also be the answer there. There should be no confusion in that case also. Okay. Eggshell calcification is seen in, well, this is not exactly my question, but at least I teach you about the sarcoidosis silicosis, so at least A and B मेरे तरफ से. और अगर आपने रेडियोलॉजी में डॉक्टर रजत की क्लास करी है, then उनके तरफ से लिम्फोमा आफ्टर radiotherapy. So answer is A, B and D is the right answer. Okay, now since I talk about the first two, therefore I have put it here. Elsewise I can say that this is halfly taught by me and half you can say from radiology, and so the answer is A, B and D here. Okay. Okay, dystrophic calcification is seen in. Dystrophic calcification is seen in. So इसका जो basic point है, you must be able to understand that. देखो होता क्या है ना कि there are two types of calcification. One is metastatic and one is dystrophic. So when I say metastatic calcification and one is dystrophic calcification, the main difference among these two is the tissue where they belong. Metastatic in living tissues and dystrophic in dead tissues. The moment I say dead tissue, the only possible answer fits into this case. देखो in amounts from serum calcium level is raised here is normal here. तो देखो hyperparathyroidism में serum calcium is raised, so it cannot be the answer. Okay, vitamin D disorder में again calcium level is raised, it cannot be the answer. In CKD, it can be hypo or hypercalcemia, cannot be the answer. So the only possible answer is metastatic lymph node, which can show you such type of calcification in which the serum calcium level remain normal, and still it can lead to dystrophic calcification occurring in dead, that is necrosed tissue. A simple way to remember an example this for dystrophic, remember a mnemonic RAT, RATNT. So it is rheumatoid nodule, okay, atheroma, tuberculous lesion, and the tumors. Tumors may it shows what is called as a concentric calcification here, and this what is called as a samoma body. It's called a samoma body. In metastatic calcification, the findings is all about hypercalcemia, which can be hyperparathyroidism, okay, vitamin D toxicity, milk alkali syndrome, milk alkali syndrome, and it could be a case of milk alkali syndrome. It can also be seen in a case of sarcoidosis, multiple myeloma can also show you the same thing, and chronic renal failure can also show you the case of metastatic calcification. Surely the answer becomes a case of metastatic lymph node is the only possible answer which can fit into this case. So metastatic, तो कुछ बच्चे ये बोल रहे हैं कि सर it was dystrophic or metastatic. यार तो मुझसे मत पूछो, you should tell me. All are metastatic except, अच्छा ये क्वेश्चन था, अच्छा हाँ देखो, some students have told me the question was dystrophic. सुनो बात को ध्यान से, question telling me sir dystrophic calcification are sorry dystrophic calcification, some question telling me, tell me true or false. Okay, dystrophic calcification is not seen in all except what was a question like this? So this would be again the same thing only, and not seen in all except का मतलब ये हुआ कि कहाँ दिख रहा है, and answer would be metastatic lymph node. I'm not sure exactly how the question would be, but if you can get the right explanation, please let me know. I'll just incorporate that too in this next recall session. Okay, basal type breast carcinoma. Again, this topic has been taught my V in the vibe session. Beta, please vibe dekh lena before the main exam. So, देखो, we'll talk about the molecular classification. Molecular classification. इसमें तीन तरह के होते हैं, 1, 2 and 3. One is ER positive, PR plus minus, and HER2 new is negative. Second one is HER2 new positive, 2 for 2. And the third one is the ER negative, PR negative, and the HER2 new also is negative. Okay, triple negative. So the answer is all of these three negative. तो actually option ऐसा था that basal type उसमें लिखा हुआ था ER, PR, HER2 new, and the option asking you what is the right answer. So all of them are negative is what is actually a case of basal cell carcinoma. The second time the question can be asked, the treatment for this is hormone therapy. Hormone therapy. This is Herceptin or trastuzumab, and this often requires a chemotherapy. The first one is also called as luminal type. The first one is also called as luminal type, is luminal A or luminal B as seen there. Okay, as seen there. This is the question number 29. So I have got two more questions. I have not been able to completely frame that in a better way, but surely I'll be giving that question in the upcoming exams also. If you have got any other recall for me, do message me in the Telegram group, and do stay in touch with me. If you have any doubts anywhere, please let me know, and I'll be always there to solve your doubts. अभी तक कोई doubt है तो please do ask me. I will be more than happy to solve that for you. Do follow me on Instagram and Telegram, और कुछ भी दिक्कत हो, you can let me know. I'll solve it for you there also. So thank you guys. If I have missed any recalls here, please message me on Telegram, and let me know how I can help you in that particular way there or not.